Hi, everyone. Welcome. Thank you so much for joining us. We're so excited to have you. Maybe to get us started, everyone could pop in the chat and tell us where you are joining us from. I'm joining from just outside of San Francisco, and I have Dr. Meg Thompson with us, who is coming and joining us from Ithaca, New York. I love it. We've got PA, Nebraska. Oh, I'm seeing so many places. It's going so fast. I love it. Yay. So nice to have everyone join us tonight. Thank you. I'm just going to give everyone maybe like one moment to just take a moment and enjoy. I saw one of our other community members saying hi from Puerto Rico, which was cool. Amazing. Very nice. Well, as everyone is settling in, I encourage you to find somewhere that's comfortable, maybe get a good beverage that you enjoy, a little snack. I've got my Pellegrino right here. That's my favorite beverage. And then I am excited to have everyone joining us. Yes, this is being recorded, and you will all receive a link of the recording, along with all of our other webinars are always recorded and available afterwards. Thank you. Oh, there's an echo on me. Is that any better?
I don't hear the echoes.
Okay. All right, thank you so much. I appreciate everyone affirming that for me. Great. Well, for those of you who do not know, my name is Madison Alig, and I'm the VP of Growth at Radimal. I am so excited for you all to be joining us for our first session of Radimal Case Rounds in 2026. At Radimal, we see some incredible radiology cases every day, and we love sharing the most interesting ones with all of you. If this is your first time knowing or hearing about Radimal, Radimal is a leader in veterinary radiology diagnostics. We combine web packs with AI-powered initial assessment and triage tool to help you give initial information into those images. And then we also have a team of board-certified specialists to give you and your veterinary teams fast and reliable imaging insights 24/7. So during today's webinar, we're going to focus on thoracic radiographs in emergency scenarios, a true game of subtle clues where even the smallest findings have a really significant consequence. So we'll see how both of these cases are interpreted by our AI initial assessment tool, as well as by our team of board certified radiologists, and how that combination supports confident clinical decision making. As I already mentioned, I'm joined today by Dr. Meg Thompson. I'm incredibly excited to have her here. She is also a veterinary imaging professor at Cornell University. And before we begin, just a few logistics. This is a race-approved CE webinar. And so you will all receive your CE certificate in your email a few days after the webinar. So if you don't receive this tomorrow first thing, don't worry, it's still coming. And during the webinar, if you have any questions, please feel free to submit them in the questions. And over then, I'll send it over to you, Dr. Thompson. Thank you again.
Hey, welcome everybody. I am very excited to be here and to talk with you all. Radiology is really my favorite modality, even though I do all of them in my role as clinical professor at the College of Veterinary Medicine for Cornell. I've worked there for about 20 years. Before that, I was a faculty member at the University of Florida for 4 years, where I did my residency. And for about since December of 2024, when I stepped down from my role as hospital director and associate dean of clinical operations after almost 10 years, I started looking for a teleradiology opportunity and tried out a bunch of companies and really fell in love, I have to say, with Radimal. I enjoy the AI, the efficiencies of the platform. And, even for me, when I was finished with cases, the confetti that was thrown up, I actually thought, oh, I won't like that, but I actually like it. And it makes me happy, and it just made me happy a minute ago. I am a previous president of the state VMA, so NYS VMS in New York. I'm currently the chair of the New York State Board of Veterinary Medicine. If there's any of you that are not from the US, this would be the discipline board of a country. I currently tutor in the first year curriculum in our problem-based learning, and I co-lead courses as well. I'm going to start with Sailor, and what I'm going to say is if you have any questions, I'm totally happy to take them during the case. Madison's going to keep track of them for me. And otherwise, if there are too many questions, I will leave it till the end of the case. And then obviously at the end, happy to take any other broad questions or go back to any cases. So the first case, and these are all cases that were on the Radimal platform. There is a function that's called Good Cases that is available, I believe, in the PACS portion, and is available to the radiologists. And we put good cases in there, and I went through and took a look at what was in there in terms of thoracic trauma, as well as some very recent cases over the last few weekends. So Sailor's the first case. He's a 2-month-old English bulldog, which we all think of immediately is a challenging patient. The clients got him a few days ago. They didn't do a lot of health checking per your superstar front desk client service manager. And she immediately noted that it was more than just the progressive congestion that the client had said was the reason for the visit, that the puppy was actually in respiratory distress. So here's the radiographs that were immediately obtained because this puppy really was struggling. Was given a dose of mild sedative to calm his anxiety so that he could have radiographs obtained. And I'm letting you take a look and seeing what you think.
Feel free to tell us what you think is happening in the chat.
Yep, feel free to put
And
it in.
I'll share what you're thinking.
Yep.
Tracheal collapse. Seeing a couple of those. Pulmonary effusion, hypoplastic trachea. This is where I also remind everyone I am not a medical expert like you all, so please apologize if I mispronounce anything. Very narrow trachea, hypoplastic trachea, tracheal hyplasia. So sorry if I said that incorrectly. Cardiomegaly, heat exhaustion, diaphragmatic hernia. Amazing answers, everyone.
I know.
Some people are asking if it's possible to see the VD view.
Absolutely.
Love this. Thank you.
And I actually absolutely want everybody to take a look and tell me what these are in the chat.
Before you ask that question, someone else said edema in the cranial chest. Someone has just said pneumonia. No diaphragmatic hernia. Skin folds. Someone said
Yep.
hiatal hernia. Excuse me.
Hiatal, yep.
Thank you.
Common in our brachycephalics because of increased airway, particularly in the bulldog.
Foreign body question mark. PRAA question mark. Caudal aorta question mark.
All right. I will address sort of all of your different answers as we take a look. Any last thoughts? So sort of the step that you would see after these radiographs were acquired and went directly from your X-ray unit and detector to the PACS, which that Radimol supplies. It would then scan the images, seconds to a minute or so, and then it produces this report, and gives you what was found, which you have over here, and many of you are already familiar with, and the likelihood of that based on the AI algorithms. There are about 50 plus different signs and I would say syndromes like GDV that the AI recognizes. And then it also lets you know what it checked as well. And then it produces these heat maps with the purpley pink being how the AI actually decided what type of signs it used to actually come up with this diagnosis or differential sign. And so if you take a look at, it says bronchial likely. I know from working with this program that it frequently says bronchial, which is something that when you use the AI, you actually come to understand what it does commonly with your images. And a lot of the times this bronchial notation is because the processing on your DR is quite sharp. The anomalous vertebral bodies, that is just a given. It's a bulldog. And then interstitial, it's looking in the perihilar region, and we will decide whether we believe that. And then redundant trachea. And I think this is really an important finding here on the AI, because it doesn't have what the actual diagnosis is as a signal that it's looking for. And that's one of the things to be aware of in these AI programs is what they actually are trained to look for. But it is something that you should think about and look at because of calling it out. And many of you did call it out specifically. And so I'll stop there and see if there's any questions on the AI report on this patient, on Sailor. And also, sometimes we'll say things like large liver in a puppy. In this case, it didn't, but it often can. So I will go through how I systematically approach radiographs, and we'll do this on each case. And I will let you know my approach. The very first thing I always do is I look at image quality for quality assurance. And the patient ID on these cases has been removed, but I always double check that there's got the date it was acquired, a patient ID, typically the name, and also where the image was acquired, which is a legal requirement in most jurisdictions across the world. It has to be part of the image, which a DICOM header is, even if you can turn it on and off. And DICOM, for those of you who don't know, is Diagnostic Images in Communication and Medicine, and that is the full fidelity image that it would be typically kind of gray, and then it has a what's called S-curve applied to it or algorithm applied to it that makes it look like a radiograph. And I also look to see if they're underexposed, which means they're grainy, or overexposed, which means I've lost some of the soft tissues, and these are quite nice. Then I look at the positioning. We've got included thoracic inlet all the way to the tip of the lungs. This right lateral is obliquely positioned, compared to this left lateral where the rib heads are superimposed. This is fine in a puppy that's not doing well. The legs are pulled forward. The lungs are well inflated, reaching the first rib and the 13th rib. The VD is well positioned with the sternum overlying it. Again, those of you that said there were skin folds, these are the puppy or bulldoggy skin folds that you see here on the neck. And they're distinct because they're outlined by air. And then from there, I do bones. And I start with bones because I always miss things and in the bones. And I literally use ABCDS. And so A is alignment, B is the bone quality, which is cortex, endosteal, and medullary cavities. C is the cartilage, so I look at all the joints. We can see that these are incompletely ossified joints because it's a 3-month-old, 2-month-old puppy, which is normal. And then whether if he had some implants, and then soft tissues. And soft tissue is your friend in bones because it'll let you know if there's a focal abnormality. Then I take a look at heart from the center, and it should be about no more than 1/2 to 2/3 on the VD or DV, and 2.5 to 3.5 intercostal spaces on the lateral. I'll look for specific cardiac enlargement, and I heard somebody say PDA. PDA has that classic 3 knobs of the aortic root, the main pulmonary artery, and the auricular bulge. And I don't see that on this case. I think this heart is normal. Then I look at the pulmonary vessels, comparing them to the 4th rib, where they cross, and the 9th rib on the VD where they cross. They're a little maybe small to normal size. Lungs, I see my vessels quite well. I don't lose the ability to see them in any view. Always got to zoom and pan so that I can make sure that I see if those bronchial markings are real. And remembering that the full fidelity image is only if you zoom and pan, because these are about 20 megabyte images each as DICOM, and you don't get that resolution if you leave them as small images in the middle of your monitor, because your monitor resolution is only then 1/3 of what it actually is, which is about 2,000 to 3,000 megapixels. And then if you zoom and pan, you can get it up to the full fidelity. And then I take a look at the mediastinum, and this is next, the obvious lesion in this puppy that most of you picked up, which is the narrowing of the trachea. And it looks narrow throughout the length of what is imaged, which is not typical of a collapsing trachea. So there's 2 things I would think of in this puppy. One of them I didn't hear and is a rare diagnosis, and one of the cases that one of our ER docs got me on was this, which is hemorrhage into the dorsal tracheal membrane from rodenticide toxicity. It was a 5-year-old Yorkie, and I just assumed it was tracheal collapse, but it's static narrowing. And the other one is tracheal hypoplasia, which I would rank first in this bulldog. 2 ways to measure it. One is at the thoracic inlet, so from the first vertebra to the manubrium, and then measuring the trachea. Normal dog, that ratio is about 15 to 20%. Brachycephalics, it's about 16%. Under that, and in other breeds that are brachycephalic, is hypoplasia. In the bulldog, that can be normal down to 12%. And he was just under 12%. So this is a congenital part of the Boas syndrome, or the brachycephalic airway obstruction syndrome. And you're all familiar with the other parts, the primary stenotic nares, elongated soft palate, abnormal nasal turbinates, as well as the secondary abnormalities like everted ventricles and laryngeal collapse. And then finally, pleural fluid or pleural space is normal. And then I look at bones again, and I won't do that. And so my report, I regret actually, in that I did not do enough to talk about tracheal hypoplasia and the measurements. And if I was to rewrite this one, all of you realizing that you can ask for an addendum on specifics or a specific question at any time, I would go in and be more specific. I chose to use tracheal collapse here because that was a tag that is system-wide. I could have put a custom tag in for tracheal hypoplasia. And I would have and should have included the idea of the tracheal hemorrhage if there was any other signs. It is a worse prognosis if the puppy has pneumonia. And that is why I suggested a canine respiratory PCR panel, which is likely given the nasal congestion. And so questions on that case? Moving on.
1 second, Meg. Sorry, apologies. I just wanted to let it come through. The lung margins appeared to be shy of the sternum on the lateral view. So how can the lungs be considered well inflated?
So I think that if you look at the right, the reason they don't quite reach is because of obliquity and a skin fold, and they are less well inflated than they are here, where they do reach the sternum. So the obliquity has something to do with it. This is probably a DV, is less well inflated because the left cranial lung lobe doesn't cross midline. But I would say that given it's a bulldog thorax, these are pretty good.
Couple more questions. Thank you so much, Meg. One is, can anything be done for this poor pup? And the second was treatment for hypoplasia will be trachea stent.
No, unfortunately, there really is no treatment for tracheal hypoplasia because it involves the entire trachea. And the reason it occurs is because the cartilage rings are small or the dorsal tracheal membrane is abnormally small and everything overlaps. And so there's nothing to expand. So treatment is really keeping this puppy out of heat stressors, which I heard some of you suggest, which is common in these guys, keeping him from getting a pneumonia, which compromises his ability to breathe, fixing any of the upper airway BOAS components, which hasn't been shown to necessarily improve the tracheal hypoplasia component of that disease or congenital defect, but doesn't make it worse. So sadly, not a lot to offer in this puppy.
Would you repeat what the normal size of the pulmonary vessels are in relation to the ribs on the lateral and VD?
Sure. So on the lateral, it is the fourth rib proximally as they about at the level they cross, and you can see that it's smaller in this case. I'm also looking for the normal taper. And on the VD or DV, it is the ninth rib as they cross. So if we count 1, 2, 3, 4, 5, 6, 7, 8, 9, we can see this vein is actually pretty much a square. And so this is a normal vein there.
Two more questions. Why does it look like interstitial loop on left picture dorsal lateral view?
I think if there's a summation of vessels, the other thing is that the caudal lung lobes are the biggest lung lobes. And so they often will look a little bit wider. And I always look to see on the VD or DV how well I can see the vessels. And I can see them quite well out in the periphery. On the right lateral, there is an increase in opacity that I failed to mention. That is a little bit of a fluid in the esophagus that is being seen.
Two more questions. Would you recommend NARS slash platelet surgery, even if it won't necessarily help with the trachea? Are there any special considerations for intubating a patient with a trachea like this? Oh,
Yes. Oh, sorry.
oh, I apologize. The question you were just answering, I must have said something incorrectly. Intestinal loop, not interstitial. I said the wrong thing. Apologies.
Which was the question on the intestinal loop?
Why does the intestinal loop look on the left picture dorsolateral view?
So I think there's colon that's visible, or cecum that's visible. They are normal size because they're definitely less of vertebral height, using, typically the L7 vertebral body height, and it should be less than 1.7, so they're still within that. In terms of intubation, that is a question that I would actually ask of an anesthesiologist, which is an easy consult. If you've got a vet school, even the one you went to, and just call and ask how they would measure, whether it would be on the radiograph, and that would be the size ET tube they would use. And then the BOAS surgery, I think, can help because it reduces the stress of the upper airway component of this disease, and kind of leaves this as the only congenital component.
Great.
All right, so moving on. This is Aries. Aries is a Doberman that they recently rescued. And he is intact, and they really want to get him neutered. They've had him about a month. His first check, it was found that he was heartworm positive, and he was started on doxycycline for Wolbachia, and ivermectin for a slow kill approach. But he's really hassling their other dogs, and they really want to go forward. He looked great when he came in for the neuter, but after the neuter, he had started to really increase the frequency of coughing. Was really noticeable, and he was coughing up fluid. So, give you a chance, take a look at his radiographs to let me know when you want me to move to the VD or DV.
So far, we see aspiration, pneumonia, fungal question mark? Fungal infection. Let's see if I can say this correctly. Histoplasmosis, blasto slash crypto, HW-induced DZ, HWD, probably also pulmonary hypertension, multifocal nodules, neoplasia, pulmonary edema, Doberman cardiomyopathy, heartworm, metastatic disease, vessel distension, patchy interstitial pattern, thrombi. I love all of this.
Yep.
Great job, everyone.
Yeah, it's great. So, I will go through it with you, but I'll let you know what the AI said. So the AI, in this case, gave him respiratory, an interstitial pattern. As many of you said, a bronchopneumonia, with the highlighting, as you see in the cranioventral lung, interstitial perihilar, there's definitely increased opacity. Spondylosis that called out, which is there. Question of whether it was congestive heart failure. Cardiomegaly, which always I enjoy because it's actually looking at the lung around it. If you look at the heat map, bronchial, left atrial enlargement, and said pleural space and mediastinum was normal. And I was a little surprised, I will say, because this program typically gets the heartworm cases quite well. And I will go through the case with you. I'm going to kind of skip over the bone. He does have spondylosis, as you see here, and go to the heart. There's moderate rounding of the right heart, a little bit of the flattening of the left side as a reverse D, which is classic. There is an main pulmonary artery bulge here, which is seen in heartworm disease at 1 o'clock, 2 o'clock. It's not a very big one, but it is there. It's a great example of pulmonary artery enlargement. So here is a cranial lobar artery, and if you count 1, 2, 3, 4, it is definitely about twice the size of the rib, approximately. It is also twice the size of the associated vein, which we're looking for symmetry. And it also fails to taper in the periphery. We do have some blunted caudal lobar arteries here, where this may be due to the fact that this dog does have has had a thromboembolic event, which would be part of what might be causing the respiratory distress. And then one of the things I look for is these vessels over the diaphragm. His are very large, so this would be a more advanced stage of heartworm disease. But sometimes you see these vessels here that you don't typically see that are bigger. And it's one of the more subtle findings of heartworm that you would see in cases that, particularly where it's endemic. Those of us that don't live in endemic areas are seeing more and more heartworm, as you know. And a lot of that is because of the rescues that are brought up to our region, though our cold winter up here probably took care of it this year. And then perivascularly, there's an increase in opacity that almost looks nodular. And this is eosinophilic infiltrate, typically in these dogs, or PIE, and is reaction to the heartworms in the vessels and the vascular changes. And this is definitely increased in him and is probably contributing to his decline after neutering. He does have a diffuse bronchointerstitial pattern as well, which goes along with the heartworm. No pleural fluid, no real mediastinal disease other than some signs of aerophagia in the esophagus and a big stomach here from respiratory distress. Anybody want to tell me if this is a VD or a DV? So what I teach, VD, it is a VD. DV would be the preference for looking at these caudal vessels, even though we can see them quite well. But what I teach the vet students is Mickey Mouse has VD. And so the ears and the Mickey Mouse face, which makes them giggle, probably isn't super appropriate, but my report here, I put heartworm in, which is a standard tag, hepatomegaly, aerophagia, spondylosis, IBDD, and confirmed some of the ones that were in there, even if they were separated, and then added to it. You can see my description, which includes a lot of normals, just for the sake of sort of continuing education via these reports. And then the conclusion here, which again, my summary is coughing is attributed to heartworm infection. I didn't really answer the question here, which was, why is he worse? And probably should have said a combination of the worsening eosinophilic infiltrate and the potentially thromboembolic event, which I said down here. And the negative findings of Caval syndrome, because I called out hepatomegaly, and the fact that his cava is normal is important. So questions on Aries?
Um, why is this considered an interstitial pattern and not a vascular pattern with the enlargement of the vasculature?
Traditional vascular pattern is actually of the small peripheral veins, is how that is commonly used. And it is used as a clinical term to denote early decompensation and heart failure. So you can be more specific in this case and say pulmonary arterial enlargement, moderate to severe, and give the differentials, which in this case, heartworm or primary lung disease resulting in cor pulmonale and pulmonary hypertension would be the primary ones.
What's Cavill syndrome?
Cable syndrome is actually where the heartworms have migrated into the caudal vena cava and are obstructing flow from the abdomen back into the right atrium. And that means that the right atrial heartworm load is very high, as to why they've migrated out, as well as the pulmonary artery load. And that's a very severe infection, and it results in peritoneal effusion and right heart failure. And they
Did you say,
typically are removed surgically. So
thank you. Did you say the dog has Cavill syndrome or does not? Sorry, didn't catch it.
does not. The cava is still about the same size as the aorta, so I don't believe he does, and he doesn't have peritoneal effusion. I can still see good detail of the here at the falciform fat. So moving on, this is Bella. This is another puppy, and this is one that they come into your clinic and you've got like post-op complication as in Aries, and now you've got a walk-in emergency and a very upset client clutching their new puppy they've had for a month, which I'm in great fear of with my little dogs, that I'm going to close the recliner on them. And this is what that client did, that their puppy got stuck in the couch and the neck and is now panting and breathing heavily. These are trunk radiographs, and trunk radiographs, I think, are fine in small creatures because the DR can accommodate, even though technique for thorax is different than technique for abdomen. So you want low KVP in the thorax to, and low MAS or abdomen, and vice versa. And then the algorithms for processing are also different, but you can see that it works just fine in this case. Thoughts on what we have going on in the puppy?
NCPE, tracheal collapse, pulmonary contusion, cardiogenic edema, cervical trachea looks WNLS with no evidence of any abruption, aerophagia, gas stomach dilated causing caudal displacement of intestines, DDX strangulation, lesion on atlas.
Yep. Lots of NCPE is non-cardiogenic pulmonary edema, if you're not familiar with that abbreviation. Luckily, that's one that stays relatively the same between places. Unlike when I came back from being hospital director, everything had a new name like HGE. So I'll move to the AI report. AI called out the kind of increase in opacity that's mild cranioventrally. It also called out bronchial as well, and interstitial. Called out the hepatomegaly in this case. Again, going to attribute that to being a puppy. Um, but it does extend well beyond the ribs. Called out aerophagia, called out that there was a little bit of gastric material in here, and the possibility of pleural fluid, which we don't have that heat map here. But you can see that that's a lower likelihood based on the AI's interpretation. What I do with this is that I use these to prompt me to go back and look at these specific areas on the radiographs, and think about whether or not that I agree or disagree. I also use it when I'm writing reports, again, as I said, to make sure that I include everything. And in this case, this one also has a differential listed, and you can think about whether or not you agree in this case. And I don't, but I do agree the hepatomegaly, and it was good for me to go back and look. These are meant as triage reports. They are meant not as diagnostics. They're aids to us all. And they are meant to reduce kind of the cognitive load, also to prompt your technicians to call out that there are abnormalities that the AI has seen if you're going between appointments and dealing with this walk-in emergency. So my interpretation, I'll start with heart. Again, I'm going to leave out the skeleton. The physes are appropriate for age of this patient. The heart is a little on the thin side, in my estimation. The vessels are a little small. They are definitely less than the rib. I don't see the caudal vessels well because I've got an increase in opacity that's unstructured, that is obscuring the vessel margins consistent with interstitial lung opacity that is extending into the perihilar region. The lungs are well expanded on this VD. And in the left caudal lung, it's actually coalescing to alveolar because I'm starting to get air bronchograms, though I still can see the margins of the heart and the diaphragm. The mediastinum's a little wide. This is a puppy. You've got normal thymus there. And the pleural space is normal, but the pleural fluid is potentially being called because of the scapular margin or the scalping associated with the costal junctions that are big and cartilaginous in this puppy. Abdomen, talked about the liver. We do have the big stomach, and that is from aerophagia. Postprandial small intestine, predominantly fluid-filled. And I'm going to conclude that this is a non-cardiogenic pulmonary edema, or NCPE. And this is because this puppy was strangled in the chair. The trachea is a little bit narrow, so this might be a little bit of edema or redundancy of the dorsal tracheal membrane, or even tracheal collapse because it does appear to be persistent. So you can see my report, and I'll stop and see what questions you guys have.
Why is hepatomegaly normal in puppies?
It has to do with the relative size to their body weight. And then the easier one to answer, honestly, and the immune stimulation, though that's typically more common in the spleen. The easier one to answer is the increase in brown fat, and is the cause of the decreased peritoneal detail. But the liver, I think we're less certain on.
Smaller vessels from shock?
Yep, I think that's probably a little bit shocky, and doesn't look like it probably has eaten recently because the stomach's not full. So both of those might be contributing.
How do you differentiate redundant tracheal membrane from tracheal collapse?
So what you're looking for, and you'd have to zoom and pan again to get full resolution, is the ability to see the tracheal rings through the soft tissue. And there is another example, and I'll show you that. So if you can't see them, then it's collapse. If you can see them and they're above the soft tissue, then it's very commonly a redundant tracheal membrane. Also look at the bronchi because they will also often be narrowed in tracheal collapse.
Can we call it pulmonary contusion?
It could be, absolutely, could be a pulmonary contusion. And that would be that he had a compression injury to his thorax. The in this case, I probably should have had it. I did say a hemorrhage is possible, which maybe contusion would be a little more specific for everyone. It's always good. I just did a seminar series on error reporting to go back and read your reports in scenarios like this to think about what you would do differently. And that's absolutely possible in this case.
Could you show the pleural fissure line on the VD? I missed that.
Yep, you can see one on the edge of both sides of the right middle lung lobe.
Would you consider mentioning the trachea narrow lumen during discussion with the owner? Excuse me, narrowed lumen during discussion with the owner?
I would, and again, that's one where I'm looking back at my report, and that's always important to review it. I didn't say it was narrowed, and I should have. I would mention it to this client because it could progress. But the deal would be that you would keep this puppy if you could in oxygen or refer it out to a practice that had oxygen, which is really what you can do for these guys, and support them through eating and fluids. Lasix doesn't help them.
Wonderful. And could you just repeat your answer regarding the puppies and hepatomegaly?
Um, my best understanding, and it's not well understood, is that it's a combination of their liver is full size relative to their small body already, and that they have immune stimulation from the gut as they the gut starts to meet the various immunostimulants and pathogens that pass through it, and that is being filtered by the liver.
Great, thank you.
Moving on, this is Reggie, and Reggie is, and I'm actually going to skip Reggie. Oh, no, I'm not. And Reggie is a Shih Tzu. He has severe mitral regurg and pulmonary hypertension. He's coughing more at home. And this is another one where your great customer service person sees this dyspneic dog and then rushes him back. So radiographs. And I will bring this one up because I think it's the most helpful.
Fibrosis?
Fibrosis, yep, good. Pulmonary hypertension absolutely can follow fibrosis, common in the Westie. This is one where you absolutely need to zoom and pan.
Someone said a mess.
Yeah, a mess. Any complex pattern in a dog lung is always bad. In a cat, doesn't necessarily mean it's horrible. In a dog, always bad. So, and this is bad. And this is one where you need to zoom and pan to tell whether this is bronchial or whether this is miliary. And I will let you see what the AI doesn't have miliary pattern as a signal that it looks for. And so the bronchial is what it calls out. as well as interstitial, and that's definitely something that you should zoom and pan to identify. The pleural fluid is being called out because there are fissures, hepatomegaly extending beyond the costal junction, bronchopneumonia because of the cranioventral distribution, IVDD given in a contradystrophic breed, and things here that would prompt me to go back and look. It says nodule or mass, and so when you zoom and pan this case, you actually can see that there are some larger nodules as well. So my interpretation is not well positioned, sternum's off to the side, rib heads aren't superimposed, but probably in respiratory distress because of this diffuse opacity in the lungs. The left lateral is the best inflated where you can really see the miliary pattern. And the heart, difficult to tell, but you get the sense that there is left atrial enlargement. The pleural space, difficult to tell because of the lung opacity. Mediastinum, also difficult to tell. Trachea often sits a little bit off to the right, which is normal. Another one, this is actually redundant tracheal membrane here because you can see the tracheal rings through the soft tissue. And so this is what that pattern looks like, where it is an incidental finding. And usually it's because the esophagus is pushing down on that trachea because of neck positioning, and then aerophagia. So this is the report of another one of the radiologists. You can see a little bit different structure. We are a mix of bulleted and prose, has to do with where we were trained, but follow the general idea of the findings, the impression, and then comments on what she would do next. And she states that that this is the biliary pulmonary pattern has gone in and made a custom tag that's available then for and client friendly, and has said that there are some more concerning larger nodules, and the most concerning for metastatic neoplasia. And hemangiosarc can do this, though there tend to be a little less defined. And then atypical hematogenous pneumonia, if it was a dachshund, I might consider mycoplasma and pneumocystis carinii. Fungal, definitely, a bunch of you said that. Eosinophilic or lymphoid granulomatosis also tend to be a little more less well defined. And then fibrosis, emerging heart failure, and suggest trying an increase in diuresis just to see if you can improve this dog's signs. So rare thing, but you guys recognize that it wasn't a straightforward heart failure, and that this was a more complex pattern. So that was great.
A few questions, Meg,
Yep.
before we continue. Just to share, teams, when Meg is referring to Zoom or Pan, that means she's talking about Radimal has a built-in web-based viewer that you can zoom or move around all of these images. There's all sorts of measuring tools so that teams like yourself can perform your own interpretation. This is also the same viewer that Meg and other specialists in our community are using to interpret those images as well. And then someone asked, why did they recommend increased diuretic?
I think that it was because of the known severe mitral disease in this dog. And the hope is that some component of that would be actual edema. But you see, she says it was less likely differential than emerging congestive heart failure is present. And increase in the diuretic dosing, I might have said diuretic dose increased trial to denote that there would be some limitations on it. The other thing in this history is the hyperadrenocorticism. And mineralization can sometimes do this, though I wouldn't expect it to be without other mineralization like calcinosis cutis, which is skin, and vessel mineralization. So there are other things I might have considered.
Can you point out the nodule or just diffuse nodules?
There's diffuse miliary nodules, and then there are some like this one here on this left lateral that are just a little bit bigger. That are what we look for in these patterns to be more convinced that they are true nodules and say not mineralization. So we're reaching a 52-minute mark. I'm going to do Bella because I think this is a good, important trauma case. She got attacked by the big dogs in their house while she was eating. And I can't imagine big dog, little dog attack because my play fighting of the two little dogs is bad enough. And so we start with this view. And again, this is a unstable patient in shock, probably. And so the radiographs are quite good quality, laterally positioned, legs pulled forward, decently expanded, though we don't reach the 13th rib back here. And
People are saying SQ emphysema.
yep, sub-Q emphysema, so gas in the sub-Q tissues up here, and as well as ventrally.
We have a rib fracture
Oh, good
or rib
pickup.
fractures, excuse me. Yeah,
Good
broken
pickup.
ribs. Good
Good
job,
pickup.
everyone.
Angled funny here on this lateral.
Hemopericardial.
Maybe pericardial effusion. This is an unusual bump here. This is the region of the left atrium, right auricular appendage, root of the aorta, main pulmonary artery.
Enlarged heart silhouette.
Heart looks.
Inverted D of the heart right side.
Yep. So the D is really on the VD. And we didn't get a super straight VD. Sternum's over here. The spinous processes aren't little teardrops, but that's because this entire right hemithorax is compromised.
Dorsal elevation trachea.
Yep, a little of that is because of this obliquity. If we go back here, yeah, I would say it is parallel to the spine. So this heart, and it's a little bit wide. So this is probably, given it's a Chorkey that's older, got some mitral disease.
Flail chest.
Yeah, very good pickup. This is a flail chest because we've got segmental rib fractures. You can see it on both views where you have kind of a displacement here of a big segment and displacement of segments here that you've got a proximal rib fracture here and a distal rib fracture here. And so flail chest is the uh, paroxysmal or the abnormal inversion of the chest wall during inspiration and pushing out during expiration because of the difference in pressure. Also have large amount of edema or emphysema and swelling on this chest wall, so it was probably grabbed right here. Lung opacity is increased. I don't see convincing pneumothorax on any view because I see superimposed gas on these views. Maybe a little bit of pleural fluid with bubbles. But I would want to be a little more sure before I sent them in to repair and lavage uh, the injury to lungs. I would expect there to be a little bit more fluid, a little bit more air. And this would be one that we would want to manage and monitor. Surgical repair of flail chest.
Two more questions
Yep.
before. Oh,
No,
um, is there something in the stomach? I thought she wasn't eating. Is the shoulders luxated? What's going on with those shoulders?
shoulders, she just got attacked, so she was in the middle of eating, so she got a little bit. This is probably colon actually back here. And those shoulders are okay. And the reason what I'm looking at is I see what you're seeing here. There's a little bit of overlap, and that's just the degree of obliquity. And because here they look like they're symmetric. So. And then I'm also really carefully looking at spine because that's another thing and scapulas, because those are things that we get kind of obsessed with looking at the ribs and the chest, and then missing some of those fractures. Also looking in the abdomen to make sure that there's no gas bubbles or penetrating wound to the abdomen. So AI in this case, it is calling out the caudal dorsal interstitial pattern. And again, it doesn't have subcutaneous emphysema as a sign that it looks for. And these are all things of these various additional signs they're always being added to. So I'm always surprised when a new one comes up that which is frequent because the product is in constant development, which is part of why I love it, as any good web-based product should be. But it did cause me to go back and look very carefully at this, which is when I picked up the flail chest that you guys picked up pretty immediately. And then we already really talked through these images. Again, sub-Q emphysema. I don't know what's causing this because I don't really see it on another view. But it probably is worth an echocardiogram in the future if there's a murmur. The trachea here, just to remind everybody, is often has a hump here because of neck positioning when it's a little more ventral flexed. And again, can see the segmental fractures. And acute traumatic rib fractures, and I've gone in and add pleural thickening, segmental fractures, subcutaneous gas, and talk about the pleural fluid. I thought at the time that the gas was not in the thorax, but did mention that wound debridement should include looking for penetration in the thorax and abdomen, which in this case always should occur. And talked about the fact that I thought the peritoneum was from bruising, not from actual overlying bruising, which is always hard in these dogs that have the overlying subcutaneous emphysema. So we
Mike, a few questions
yep,
about that case.
yep.
Can we consider abnormal that the heart is lying down almost entirely in the sternum in the lateral view?
Yeah, I mean, it would make me worried that there is a right-sided enlargement in this dog. But that fakes me out a lot because of chest conformation differences, degree of inflation. In cats, that can be absolutely normal. But if there was a murmur in this dog, I would absolutely suggest that it have an echo. Um, it is one where if you had a straight VD, you'd better be able to tell. But at this point, what's important is that dealing with the trauma.
Because the fracture of the rib, would you recommend to retake images to confirm not protruding or producing pneumothorax?
Yeah, and your protruding lung is a good thought. That is another thing for the sake of completeness, should have commented on, because that can occur in these flail chests, even in the rib fractures, and those need to be very specifically addressed because sometimes they actually need mesh surgical repairs to keep them in. But yeah, repeat radiographs after this dog has been in oxygen and gotten pain meds and is a little more stable, treated for shock, would be good to see if the pneumothorax is developing.
You said that the heart in dogs should be 2.5 to 3.5 rib spaces on lateral views, right? How about cats?
Cats, it's 2 to 3. And then cats on the VD is about 1/2 of the thorax width.
Someone else asked, as a radiologist, can you give any comparison between Radimals AI versus Signal PET versus Antec? I think there are a few others. I've already affirmed that Radimal is a patent technology, and we are the only provider in the entire industry that exclusively trains our AI with our team of board certified specialists like Dr. Thompson. But perhaps you could speak to this from your perspective.
Yeah, so I don't have experience with the other products, though I would like to. I do know that the Radimal, right from the start, was trained with radiologists. I would say also, to be fair, that Antec was as well. You have a variety of data that's available. So Radimal talks about the critical findings and the 99% triaging appropriately of those critical findings. And that data is updated all the time. The radiologist part of the interpretation is we tag both in the report with the custom and drop-down tags. And we then also additionally can tag whether it's a good example of a normal or a good example of pleural fluid in a secondary screen. And on top of that, there are sets of cases that are offered to the radiologist to specifically train the model on either a new signal or to verify that there hasn't been drift, which is in all these cases that are continually these LMNs or large language models that are continuing to learn, as this one is, that it hasn't drifted. And so there's that step of testing a new one or checking to make sure that it is not drifting. And then there are accuracy measures that can be done. And I can tell you that I did a project with Radimal looking at small intestinal obstruction. And one of the things to know about that you can increase the threshold on a more severe finding. So like congestive heart failure, the threshold of when the program calls it out is higher or is lower. So it calls it out sooner because of the severity of that finding. And so in small intestinal obstruction, that threshold is set low. So it gets called out frequently. But truthfully, it was 70% accurate when I compared it between known mechanical obstructions on the Cornell caseload and known functional ileus and gastroenteritises. So 70% is actually what radiologists can do, looking at abdominal radiographs compared to abdominal ultrasound. And so it's on par with the radiologist. But so if it calls it out, that's one I would absolutely send in. Any other questions? So I'll move. There's some other cases, and I'd love to do those again in the future. The next set of cases are actually going to be thorax, and the next CE is thorax. So you guys will get to see some of these and talk through more of these cases. and maybe see some of these because this is a complication in hospital. And thank you. And again, I would urge you to try Radimal if you haven't tried it, and see what you think, because my personal reason I love it is not only the AI and the ability to triage cases, and which we use at Cornell. We use it in the ER at night, and they triage using it. And then they send out stats to Radimal to read. And also is the efficiencies that it has built in. So it has generative learning efficiencies, like starting to write reports for us, and it double checks our reports, and it catches our mistakes on left and right, numbering, metacarpal, metatarsal. So those are also available on the front end as well.